Hi everyone and welcome to my presentation. Today we're going to look at the Pulma Vista 500 by Draeger. Pulma Vista 500 is an electrical impedance tomography and it helps to visualize the distribution of ventilation within the lung. And this gives dynamic images in real time. And the great thing about it, it's directly at the patient's bedside. It doesn't use any radiation and it's a non-invasive monitoring device. So the way the electrical impedance tomography works is there's a rubber belt with 16 electrodes that go all around the thorax. So there's a belt, there's 16 electrodes, and what it does is it sends a low frequency current, and that current crosses the lung. During the respiratory cycles of inhalation and exhalation, it measures different levels of impedance. So impedance is basically resistance. So the more air that you have, the more the signal is impeded, and the less volume that you have, there's a decrease in impedance. And from this, you can get a computerized image of the distribution of ventilation. So here's the belt, and this, they say to put it between the 4th and 6th intercostal space, and that's about 2 inches below the armpit of the patient. This is the normal distribution of ventilation. So there's a template that goes all around on the screen to kind of give you a perspective of what you're looking at. So this would be the vertebrae and this would be the sternum. So this is a caudal to cranial view. So it's like you're at the foot of the patient and you're looking towards their head. So this would be another way. They call it ventral, mid-dorsal, and dorsal. You could call it anterior to posterior. So this would be the right side of the lung, and this would be the left side, just like a CT scan, the way you look at a CT scan. The aeration, when there's 10% of the volume being distributed to that area, it'll start appearing as blue. So this blue area all here is the aerated lung. Where there's the majority of ventilation, it shows up here as white. So within the distribution of ventilation, you're going to see white appear, and that helps us show evenness of distribution. So if you'd have a lot more white in an area, you'd understand a lot more of the ventilatory power or the stress is going towards that area. So you want to have as much as possible even distribution of this white inside of the blue. If you're under 10% of distribution, so sometimes in certain images, you'll see that there's black, that there's no blue. Doesn't mean that there's no distribution at all, but it's usually smaller, under 10%. Here, there's global measurements. So I like to compare that to an iceberg. So when you arrive in the ICU and you're looking at the vent screen, you're only getting a very, very limited amount of information about the lung. So you have the global measurements such as plateau, compliance, you can get drive pressure measurements, but you really don't see what's happening inside the lung. So that's kind of like under the water, where the boat would only see the top of the iceberg and would not be able to describe underneath. But with the electrical impedance tomography, you get also regional information to add to the global information that you're getting from the computer screen. So you can get such things as end inspiratory lung volume, which is really useful for recruitment maneuvers, and expiratory lung volume. So this is great for recruitment or analysis of your functional residual capacity, the residual volume at the end of expiration. You can get regional distribution of ventilation, as well as changes in regional compliance, which allows the electrical impedance tomography to do optimal Peep studies based on regional compliance. So this is the main screen. And over here, you'll see this is a screenshot, obviously, but this is actually a dynamic real-time inspiration, expiration. So you see a dynamic image here. You'll see the last title image appear there. You can divide these into regions of interest. So you can have, as we have here, ventral, mid-dorsal, and dorsal, or you can put these into quadrants and you can adjust. Often we're going to use layers because what we really want to see here is the dorsal or the gravity-dependent regions. Over here are percentages. So the normal for the ventral area is 8 to 15, and the dorsal is also 8 to 15, and the mid-dorsal and mid-ventral areas are 35 to 40. These curves here are the impedance curves, but like we mentioned initially, impedance is volume. So they're pretty much equal. So these would match the volume curves that you would see on your ventilator. If you're connected to a Draeger product, because the Palma Vista is a Draeger product, you'll also have the tidal volume that appears there. So you can multiply, let's say if you had a tidal volume of 500 by 8%, and then you'd know in milliliters how much volume you're getting in each of those layers. Here we're looking at the end inspiratory trends. And for this specific example, we see over here, this is a PEEP of 5. And you're going to have all of the information over here, the percentages of distribution of ventilation, as well as the parameters set on the ventilator and the time, so that you can kind of know where you're going. So this is a PEEP of 5, and right away you see with the PEEP of 5 that there's poor distribution of ventilation to the dorsal region here. It's appearing quite dark. And because there's no aeration in the dorsal region, then the tidal volume that's being administered here tends to go upwards towards the mid-ventral and the mid-dorsal region. And we see this white intensity, as mentioned before, which helps us see the evenness of distribution. So we see that there's more going on the right side, and that the majority of the tidal volume seems to be trapped in the mid areas. Over here, you have a PEEP of 14. Now you see with the PEEP of 14, we've managed to open up the dorsal region here. So if we look at the white, we see that it's much better distributed now. It's kind of evened itself out. And over here, this is just basically a color-coded way of explaining what's occurring here. So orange means a loss of ventilation, and blue means a gain. Now, orange doesn't necessarily mean that it's a bad thing. In this situation, it's not a bad thing. Because if you look over here, look at the intensity of the ventilation with the PEEP of 5, and we've lost that intensity. Why have we lost that intensity? Because more volume has been distributed here. So that's how it's represented. This area here is now open, represented by the blue area. And because it's been redistributed down here, we have less trapped in the mid-ventral and mid-dorsal regions. If we look down here, the PEEP of 5 only had 3% of distribution to the dorsal region. And now we've come up to 12%. If we look here, these are the impedance curves. As you can see up here, this is your PEEP of 14, goes down all the way to 6. So we have 14, 12, 10, 8, and 6. Underneath here, this is actually representing your functional residual capacity. So at a PEEP of 14, we see that the impedance curves or the volume curves are maintaining in a straight line. That means that the 14 has recruited this much functional residual capacity and is able to maintain it. We also see 12 as well as 10 maintaining the functional residual capacity quite well. But notice over here, 8 and 6, there's a downward trajectory. That means that at a PEEP of 8 and a PEEP of 6, we're no longer able to hold open this area. And we're likely going to end up collapsing the dorsal region because of a suboptimal PEEP. Over here is your reference, and you can compare, here we happen to be comparing 5 to 14, but we can be comparing 14 to 6 over here. So we can scroll these reference and the control to always analyze two different parts. So here it's 5 and 14, but we can scroll all along here. And this here is the tidal volume. In yellow, it's the peak pressure, just the same colors as here, so that we don't get lost. So we can do all of these maneuvers on our vent. And then once we go for the analysis, we can scroll all along the time axis. Here, if we want to look at this area, the functional residual capacity, we want to look at that in more detail. We can go here to the end expiratory lung impedance. And you see the similar impedance waveforms over here, as we just saw. Over here, we have the impedance values. This is the global impedance value. And then you have basically, if you add up these, they add up to 2.26. So here's your ventral, mid-dorsal, and dorsal again. Now, remember that impedance means volume. So right away, I see the positive impedance values, and I say to myself, okay, I know that there is an increase in the end expiratory lung volume. But if we want to translate these impedance values into actual milliliters so that we better understand how much air has been gained, what we'll do is we'll just multiply that by the reference tidal volume. And it says it right underneath. So it says multiply by tidal volume for global reference. I've done the math for you over here. So by increasing the PEEP from 5 to 14, we've been able to add 1.48 liters or 1,480 milliliters of volume at the end of expiration. And we can multiply the impedance values by the reference. And we see here that 60 milliliters at the end of expiration has been gained. Again, we have the color-coded area here. And since these are all gains, pretty much everything's blue. So if we would have lost in an area of functional residual capacity, it would have showed up in orange. Remembering our pulmonary function tests, 2.5 liters is the normal functional residual capacity. So you see over here, seems like a lot of volume, but it's normal, especially when we're going from a PEEP of 5 to 14, to have a decent amount of volume change. Since the electrical impedance tomography can analyze regional compliance changes, it's able to do very accurate Peep trials. So we'll use this for optimal Peep studies. And all you have to do is try different varying Peeps. Usually they suggest to go by 2. And you just do that incremental or decremental Peep trial on your ventilator while you're connected to electrical impedance tomography. It will capture all of these changes. Over here is 14, and we go all the way down to a PEEP of 6. We see the tidal images that we recognize over here. Remember the loss in the dorsal region? We see that we recruited at 14. Over here, the orange represents a loss in compliance. CLHP means compliance lost on the higher PEEPs, and CLLP, compliance lost on the lower PEEP. So we see at a PEEP of 14, we've successfully recruited the dorsal region. However, there's some overdistension indicated by the color orange. In fact, there's 21% compliance loss in the ventral regions. As we go to 12, there's 16, go to 10, PEEP of 10. So we see that there's less and less overdistension. But now we're having the color here that's white. Now there's a compliance loss. As we go towards the lower PEEPs, there's a compliance loss at the bases, indicating possible de-recruitment. So below here, there's these vectors, and it's the same numbers that you see up here, 21, 16, the same thing with the white, 20, 10. And usually where both of them meet, where they both cross, this is what is basically the least overdistension and the least de-recruitment. So right about here would be ideal. Now, this is a monitor, so you still have to use your clinical judgment. If I have a plateau of 24, if I have a very safe plateau, I have a morbidly obese patient, I'm more concerned probably about the atelectasis and this de-recruitment indicated by white, the loss of compliance on this low part. So they suggest over here indicates the least amount of overdistension, the least amount of de-recruitment, but we still have to use our clinical judgment. And if you have a morbidly obese patient with pretty safe plateaus, perhaps you're going to go more between 12 and 10, perhaps 11 would be ideal. But in general, a good area is when they both cross, you're getting the least amount of issues. Over here, when I look at this example, this is from 14, 12, all the way down to 6. This is another example. You can see right away here, the green is the PEEP settings, and you can see that the PEEP is set here, and you can see that it's holding these impedance curves. As you go to 12, holding pretty well, 10, not bad, but then you see it starts to go below. So right away, your eye catches that. Another thing that catches my eye is here, these yellow over here. So this means instability, alveolar instability, means that there's a residual volume delay. Basically, when it comes to the PEEP studies, you don't want orange, you don't want white, and you also don't want this yellow. It indicates that the alveoli are unstable. So right away, 6 and 8, I know that I'm not going to be choosing these two. So 6, 8, all of a sudden you go to 10, there's no more instability. There's still some loss of compliance, 21%. So I know 6, 8, and 10 are not ideal. Then I come over here and I evaluate 12. There's 9% compliance loss over in this region, very minimal loss here. So the ideal PEEP is actually close to 14. There's 0 loss of compliance at the base. Some could argue perhaps 13 would be best, but we can tell right away that this area here is definitely not optimal. You can actually press over here and you'll be able to see in more detail. The yellow areas are areas that fill later, and these ones fill earlier. So the tidal volume goes in, it's filling these areas here, and then after there's a residual time before these are filled. So that gives you extra information if you press on there. Here's an example of the distribution of ventilation on the Palma Vista, and we can see how accurate this technology is. Here's the aeration of a CT scan. You see it's aerated here. You see this huge consolidation. You can see that consolidation on the X-ray. You can even see the air bronchograms showing the adjacent alveolar consolidations. So this was an important picture, and these kinds of pictures were important initially to convince the doctors also that this technology is highly precise. And we don't have the luxury of going to CT scans and setting various PEEPs and then taking CT scan images. But when it comes to the aeration information that we get from a CT scan, we can get all of this with this non-invasive monitor using 0 radiation. So here's a little video, a dynamic image of that. Here's your first dynamic image of that. You can see the white. When we tried to increase pressure, the white intensity just kept on getting more and more intense. So we knew that we were just not doing anything good by trying to recruit any of this area. Unfortunately, this is what occurred later on. This patient had a unilateral pneumonia and ended up having to get transferred for ECMO. Here again, we see the distribution of ventilation compared to a CT scan, very accurate. There's a pleural effusion also in this area, and that shows up as a negative impedance, a purple area. So we can often catch pleural effusions, or if there's a significant amount of fluid, you can catch those very early. And it can help also the doctor to decide whether or not they want to tap that and remove it. Here you see that the distribution of ventilation is seriously affected in the left lower quadrant, the left dorsal and mid-dorsal region. Just going to play another video here. You see over here that there's a possibility of some ventilation occurring here. So it's going sometimes down here. So we decided to try APRV, but before the doctor wanted to try higher PEEP, so we did a PEEP trial. And this is the PEEP trial here. On this screen here, you're seeing 18 to 10. Here's 18, here's 10, over here is 10, and you can see by increasing 12, 14, 18, 20, you see that there's compliance loss. By the time we're up to 20, we're at 52% less compliant. So this patient did not respond at all in a good way to higher PEEPs. And that's the issue also with some of the doctors that want to use the ARDS net, where there's a PEEP adjustment based on FiO2, which is really not individualized to the patient. So if we would, this patient had higher FiO2s, if we would have tried to just place the PEEP based on FiO2, we would have did considerable harm probably here. So you see that the loss of compliance is all throughout the lung. So the best PEEP actually is 10. In fact, I redid it with a PEEP of 10 down to 7, because 10 was the best compared to 20, but perhaps 8 or 7 could have been better. And we see over here, the blue appearing. Now the blue here in this one, this screen, we have a PEEP trial, and we also have a custom analysis. In this one, I'm actually using custom analysis. So if you check over here, it doesn't have that CLLP, the compliance loss on the low part, or the compliance loss on the high part that was previously orange. This one is CW, compliance win, and CL, compliance loss, and that's in percentage. So we see that the lung with a PEEP of 8 and 7 is becoming more compliant in this region. And we also see that once we hit 8 and 7, there's less instability, that yellow area. So the optimal PEEP would be somewhere between, I guess you could set it at 8, 7, 7.5. Next one. So we also decided, since we had the Palma Vista on, which we often do, if we don't get the recruitment that we want with traditional ventilation and higher PEEPs, we often try APRV. So this is a little trial on APRV. So over here, you see that higher mean pressure that we can get with APRV is actually successfully starting to push back against the pleural pressure here. And we're getting pretty good distribution of ventilation. The white here indicates that there's still a good amount going to the ventral areas, but we could do two things. We could wait it out and we could see if this white starts to become more uniform. Already we see some white going down to the dorsal areas, or we could play it safe. Another thing we could do is actually prone the patient. By proning the patient, we're going to put more weight on the ventral areas because the patient's going to be lying on their stomachs. And we could be, in a way, splinting this area here. And that dorsal region that no longer has the weight of the patient could open. And you'll see in the coming videos, we've done this a couple of times pretty successfully, where we see the possibility with APRV of opening up here, but we have that white area. So proning, we've had some good results if we actually see this pattern and end up proning. So here's the comparison of Acpc compared to APRV. Here we have the end inspiratory lung volume. So here's the comparison again. We've opened up primarily this region. This gain is showed by blue. We do see quickly here an increase in this functional residual capacity. Remember, these are impedance curves, which are equal to tidal volume. So you see here, the green area is the PEEP, and here's when we transitioned into APRV. And you can see here, that was a PEEP of 10 that we had tried here. And once we went to APRV, we had quite a significant gain in the functional residual capacity. Here's a little edit from one of my YouTube videos. So what we do often is, once we do the Palma Vista, we do the traditional Peep study, where we'll try varying PEEP levels and we'll look at plateaus. We're going to look at the drive pressures. So we do the traditional part. Then after we transition to Acpc and we do the PEEP studies, just like we've seen before, then we do a trial APRV. I'm not going to go into what auto release is in APRV too much, but the way we use APRV is that we set the P-low at 0. And what we do is we set the T-low to trap 75% of the peak expiratory flow. So I have the P-low at 0. I'm going to look at the peak expiratory flow. Let's say it's 100. I'm going to multiply that by 0.75. That's 75 liters per minute. And I'm going to take the timestamp of those two areas, and I'm going to set that as my T-low, which ends up trapping 75%. And that determines a P-low, which is measured by a expiratory pause. Here's what I did with the traditional ACVC. So I tried PEEP 8, 9, and 10. There was a total PEEP of 9.1. When I set it at 8, 9.9, and 11.8. The drive pressure was 18.7. In a way, I should have did a PEEP of 6 and tried it, but in this specific case here, I did 8 to 10. So obviously the drive pressure of 18.7, it jumps up. Here, the plateau jumps up. So the optimal PEEP based on the ones that I looked at would be a PEEP of 8 with an intrinsic PEEP of 9. Over here, we have 6, 8, and 10. You see also, just like up here, that there's a jump when we went from 10, it jumped by 3 units of pressure. And you also see here with the Peep study of Peep of 10, you start seeing that trend where you're starting to lose compliance. So the optimal Peep is 8 with an intrinsic Peep of 9.1. And when you use APRV and trap 75% of the peak expiratory flow, you usually get a very stable alveolar recruitment. And quite often, after doing this over and over and over again, not all the time, but it often lands really, really close, the P-low, to the optimal Peep. And we see it's 8.9 here with the measured expiratory pause. I'm going to show you another video to get some more dynamic images in. This is going to be on Acpc with the optimal Peep set at 8, and then I'll transition to APRV. You'll see the T high and the higher mean pressure that we get with APRV, and you can see the difference in the distribution of ventilation. With Acpc, on inspiration, you'll see the blue up here, and on expiration, it becomes extremely small. And then you don't really see that with APRV. So let me show you this one. Sorry, my hand's going to be in the way. So this is Acpc with the optimal Peep. Here's my hand getting in the way. I have the volume off of the video, but I'm kind of pointing out how small sometimes the blue gets on expiration. Here is APRV, and you're going to notice already that you're starting to get a little bit more stretch going. You're recruiting a little bit more. It's going to start going here. So this is what we usually do if we have the benefit of having the EIT belt on, especially if we're not getting what we want with Acpc. We're going to compare the conventional mode to APRV. Here's just another beautiful image. Look at how it's well distributed. The white is evenly distributed. You can tell that this is APRV. There's probably about a 2 or 3 second T high. So this is a really, really interesting case. This is one of my favorites. What happened here was an aspiration during anesthetic induction. So they performed the emergency surgery. The anesthesiologist did a bronchoscopy, tried to remove some of the aspirate inside the lung. These are some of the images. So they called me into the recovery room because the patient was going to be admitted into the intensive care unit. The FiO2 was at 100. We were satting about 89, 90, having trouble oxygenating. Over here, you see that the majority of the ventilation is in the ventral and mid-ventral areas. You can see this left dorsal area is the most attained, but you can see this is not a normal distribution of ventilation. We tried APRV, and over here you see this white bar. So we're definitely getting a little bit more ventilation to this area, but there's this white area here, which shows the majority of the ventilation is going to the ventral areas. So that puts the ventral areas in danger of overdistension. We could run into trouble by causing some lung injury here. So we decided, since there was some potential with APRV to get a little bit more aeration at the bases, we decided to prone the patient. Again, by proning, you'll have this area will be down. You'll get a better ventilation to perfusion because when you put the patient in a prone position, this will come the gravity dependent regions. You're also putting the body weight now on the ventral areas when you're in a prone position. And that's a good thing because it's kind of going to splint this area here and encourage the vent power to go more to the dorsal areas where we actually want to recruit. So we got to the ICU. I took a picture here of the patient in the prone position. Here we have the belt. And look at the beautiful result that we received here. Beautiful, even distribution of ventilation. Not too worried about that slight intensity over here. Let's look at a small video. So I sent a 24-second video to the doctor. I'm quite happy and giddy because of the amazing result, and you'll probably hear that in the tone of this video. When we were in the recovery room having trouble with the dorsal region, and watch this. Boom! I love my job. He's down to 35%. We got a P high of 18, and he's setting
94.
So here you see within basically an hour and a half, while we use the EIT to guide all of our decision making, we were able to get the patient from here on an FiO2 of 100 to over here, like we had mentioned before, right away turning the patient prone. That would have helped the ventilation to perfusion because we did have good ventilation there. We had a very impressive result. If you notice in the video, we're using a very modest P high of 18. We were stretched to a T high of 5, and we're at 35% oxygen. Here's another case that we had where we had severe abdominal distension. It was a post-op patient. CT scans showed a very dilated colon. So we're definitely having trouble here with the dorsal distribution. That's at 4%. That's why it's mostly black. Remember at the start, I said the blue really starts appearing when it's 10%. And when it's below that, it'll show up as black, but we're still able to get the information that there's 4% of the 308 that is still being distributed to the dorsal region. We look up here, you notice that there's no PEEP, there's no green PEEP line. This is on APRV. So we use the customized analysis. We're looking at CW in blue for compliance win. Compliance loss will appear in orange. We're using very high pressures, and we would never really do this unless it was guided by tomography, but there was significant distension. So we have to push back against that pleural pressure. So A, B, C, D. So I put the numbers up here. A here is 40, 38, 36, 34, 32. Already at 30, where you would say, well, 30 is protective lung ventilation, we're actually losing compliance at 6%. And as we trend below 30, we're seeing more and more compliance loss to the point of being at 24, we have 16% compliance loss. So the optimal PEEP would actually be quite high. Another way that you can get information is looking at the FRC representation underneath. At A, B, and C, we see that we're holding the line here. But once we hit D, we start seeing this downward trajectory here. So the optimal PEEP would be somewhere between 40 and 36. Over here, we tried another one. Again, we look at A, B, and C. The numbers are up here. This is 36, 32, 28. We did 24 twice. This was after some time. And again, in this study, 36 would have been optimal. So a lot of pressure was needed to keep this lung from collapsing. You can see D and E, 24. Look at the white appearing, the compliance loss. You're also seeing an increase as we go here with the yellow, meaning somewhat of an instability. We can see it color here, that yellow. So if you're actually taking into account the yellow residual volume delay showing possible cyclical opening and closing, actually A would be optimal because we're starting to see yellow. So at least we're also getting away the yellow here with 36. So we see here this upward trajectory. And then as we go lower, we can start seeing it going down. So a tremendous amount of pressure was required to keep this lung open. All right, let's go to the next one. Here's a video.
Okay, so yesterday we had a tomography when the patient was on their back due to a extremely distended colon on a CT scan yesterday. There was distribution in the ventral and mid-ventral areas, but there was none at the dorsal area. So we put the patient in a prone position, and this is what we see this morning. A wonderful distribution of ventilation, a little bit more in the mid-ventral to ventral areas, which is fine. So this is a nice even distribution, a impressive difference just by changing the position of the patient, pretty much keeping the same parameters that the patient was on yesterday, APRV. We titrated and did a P high trial, and the optimal P high was 30 to 32. That doesn't mean now that the patient is on their stomach that 30 to 32 is optimal. Still, it's kind of like doing a PEEP study. Let's say the patient needs a PEEP of 16 because recruitment's occurring at 16, but within 8 to 12 hours, perhaps that 16 is no longer necessary. We can maintain that recruitment with less. I'm going to take the freeze frame. So this is the dynamic image. So the prone position really did its job. The FiO2 was on 100 yesterday, so now we're down to 75. So it lowered it by 25%. This over here is the patient that is the next day, the 8th, in a prone position with the belt that was put on backwards. So here you have a slight reduction in the ventral area at 5%, but the rest of the distribution is good. This is yesterday, the 12th. This is what I was talking about, the distended abdomen and the extremely dilated colon. So we see that this is a patient when the patient's on a supine position, and you can see due to that increased pleural pressure and a complete elimination of aeration at the dorsal region. So we decided to flip the patient at the end of the shift, and here we are this morning finally with this result. So very, very good result with the proning.
As I mentioned in the video, a really, really good result with the proning of the patient. We see the white well distributed all throughout the lung, a little less here. So this patient had a very good result, and we did a study again because we've had tremendous changes in the distribution of ventilation. Did again on APRV, going from 32 down to 26. And we see that the patient is still optimal at 32. We see that when we hit 28 over here and 26, we're starting to lose compliance in this region here. Don't forget, this is a prone patient. So this here is actually the dorsal region, and this is the ventral region. Unfortunately, the template around this cannot be flipped around. So when you have a prone patient, you have to just remember that this is actually the patient's chest and this is their back, which is normal. This is where the lower PEEP, you would be losing the dorsal region. Look at another video. This one is a recruitment of the left dorsal region. So here's a example of a spontaneous breathing patient. This is the distribution of ventilation seen with the Palmavista 500. This is a patient on pressure support ventilation. We did a PEEP study, titrating the PEEP right up to 14. As you can see here, the left dorsal region, there's no ventilation. So we did the PEEP incremental PEEP study in an attempt to open up that dorsal region. Here's the actual PEEP study, and when we did from 8 to 14, on the right of your screen, you see that orange. That means over distension. So we were able to get a little bit more distribution to the dorsal area with the higher PEEPs. However, with the orange that you can see over here, signifying over distension and a loss of compliance in that area, it wasn't an option to use that higher PEEP because it would have put in danger the ventral area of the lung to over distension. So here's just the full screen image that you can use when you're outside of the room. It's bigger, you can see it from far. And yeah, you still see the left dorsal area. So we put the patient on APRV in an attempt to open up the lung. We had some modest settings. The P-high was set at 20. We had an initial T-high, I believe, at 4 seconds. We were using the auto-release option. And this is what the tomography looks with the APRV. And as you can see, that left dorsal region has completely opened up. Here's an image of the next day. So we see that the APRV was able to correct the left dorsal region. There was less overdistension seen on the ventral areas. Because recruitment is pressure over time, when you're using APRV, you can increase the time, and very often you require less pressure. So this is a good option if ever you see that there's regions that are not ventilated. It's always worth doing a run of APRV to see, because as you know, with the higher PEEPs, we were causing overdistension, and that wasn't the case with APRV. Here's an example of Optiflow. So we put the electrical impedance tomography on the patient while the patient was on Optiflow. This is a COVID-19 patient. So with the COVID-19 patients, they have very, very high respiratory drives, breathing at 35. That tends to be a rapid and shallow breathing. There's some literature that's out there about possible self-induced lung injury. So we use CPAP quite often to try and splint the lung open. It often helped with oxygenation also, obviously, but it also was an attempt just to splint the lung open to prevent a lung injury that could occur. So right away, you see, compared to the Optiflow, that there's an increase in the distribution of ventilation, especially here to the mid-ventral area, as well as the dorsal area. This is represented, again, blue meaning gain. So there's a gain with the CPAP compared to the Optiflow in these two regions. We're going from 8% at the dorsal region right up to 17%. And this occurs quite rapidly. We can see over here, this is 9:47 to 9:55. So this was almost immediate. And I kept it on, and this is what it looks like after 2 hours. Very even distribution of ventilation. This is represented here in blue. And you have the functional residual capacity. We weren't connected to a Draeger ventilator, so we didn't really have the numbers here, but this upward trend means that we're also recruiting end expiratory lung volume, 8 to 18% at the dorsal region. This is another case of a patient in a supine position, very, very poor distribution of ventilation, something you would see in a severe ARDS. We call this baby lung effect. We decided to prone the patient. So this is the patient the next day in a prone position. Again, don't look at the template. I put this on backwards, the belt. So this is actually what the lung looks like. The chest would be here, the spine would be here. This would be the right side and the left side. There's a little bit here of lack of ventilation, perhaps because the patient's just the pressure of the patient lying on their chest. This was an opening. The hope was once we turned the patient back into the supine position, pressure would be relieved from here and we would maintain the recruitment and also pop this area open. Again, this is the prone position. And when we put the patient back supine, we see again a distribution to both ends. The dorsal and ventral regions became better distributed. Remember here, the air is kind of trapped, shown by the white intensity. And once we turned the patient, the loss of intensity here, because it was redistributed up here. So this orange represents the loss of distribution here, because of the redistribution to the ventral and dorsal area. We wanted to make sure that the end expiratory lung volume would be maintained. So again, you see here, we didn't keep it on too long, but we saw all impedance values were positive. And we saw here, this is represented by a gain in the functional residual capacity. So we were confident that the patient wasn't going back the other way. So for this one here, we have a PEEP of 12 and a PEEP of 16. Over here with the PEEP of 12, again, you see that there's a majority of the ventilation going to the ventral regions. Once we increased the PEEP to 16, we had an improvement, especially in the left dorsal region. So this trapped air here was able to better distribute towards the dorsal region with the PEEP of 16. This is represented here by a downward trajectory in the distribution, which is a good thing over here. And you see the difference here, much more ventilation here, less there. That's represented again by orange. The increased ventilation that is here, better here, that's represented by the blue. We see the impedance curves going up, and we have 12% distributed over here to this region, and we were able to increase this region here to 20. So you notice here, we're not doing it in layers, we're actually doing this one in quadrants. We see the upward trajectory here, saying that we're recruiting functional residual capacity. And to be honest, we see this even just with the 12 going up here. We could have been patient and waited for this recruitment to happen on 12 completely to straighten out, and then after go to the next one. When you increase PEEPs and you just see it increase and it stays straight, you know right away that you're not recruiting any further functional residual capacity. So it's a quick way of looking for recruitment. We also see here, we could do the same thing just for time. I'm not going to do it. We could multiply all of these by the reference tidal volume to get the actual milliliters of volume for the end expiratory lung volume. Same thing. This is color coded, all gains here. That's why it's blue. So with APRV, we use the customized analysis, and we use different P high settings. For this example, 20 to 30. So whenever we're using APRV, we set the tomography and we do a PEEP study, and we set the P high based on compliance. So over here, you see from 20 right up to 30, and you see that we're winning with every increase in P high. We're winning to, I think it's a little cloudy, 34% gain with a P high of 30. So this is how we usually set our P high when we're in APRV. And that's the end of the presentation, everyone. I also have a YouTube channel called the Palmavista 500 Guided APRV. It's a small channel. The Palmavista 500 is from Draeger, the company's Draeger, and I spoke to them recently, and the Palmavista 500 should be available in about 3 years. If you have any questions, please feel free to email me at jjswartz79@gmail.com. Thank you very much. The end.